Over the last season of this podcast, we've spoken with nurses from across Canada. Not administrators, not spokespeople, but people at the bedside. And what surprised me wasn't just exhaustion, it was fear. Fear of missing something critical. Fear of making a mistake that could really hurt someone. Fear of knowing exactly what good care looks like and being unable to give it. We often call this burnout, but burnout sounds personal. And what nurses are describing is really something else. They're describing a system that no longer protects patients or the people caring for them. Today's guest hears these stories every day. Linda Silas is the president of the Canadian Federation of Nurses Unions, representing more than 250,000 nurses and nursing students across the country. I'm Dr. Mark. Welcome to this week's episode of the Caregivers Podcast. Linda, are we as a society asking young people entering the nursing profession to take on a job and a burden that's fundamentally going to break them emotionally, mentally, and physically for the rest of their lives?
Interesting comment, Mark. I would flip it. I think as society, we have to take a grips of what's happening in our healthcare system. You know, I represent nurses, but I always say that healthcare is the biggest team sport we have because we all have to work together. And yes, the realities of today is what you said. It's breaking people physically. We have the highest physical injuries, but we also have the highest mental health injuries in any industry. And that is not right. So as society, we need to commit to turn this around because we have great nurses, great personal care workers, great doctors in the system that want to continue for 40 years. And right now they can't. So how do we turn it around?
Fundamental question. So you look back at 2025 and you define it as the year that was defined by your fight. For listeners tuning in today, what's one story that resonates with you and that you just can't shake from your head when you think back to that fight and what you're fighting for?
It's probably that nurse from Newfoundland and Labrador. I don't want to specify where she worked, but I was at a social reception with her and she was kind of high energy and kind of bubbly. And I said, "Oh, did you work hard? Did you have a nice shift?" "Oh," she says, "Linda, excuse me, I just finished my 30-hour shift and I'm okay, but I just finished that shift." And I looked at her and I said, "Where do you work?" "Oh, she's intensive care. But don't worry, I only got confused around hour 20. And I'm like, mind-boggling. And that really did a turnaround for our organization. We summoned 2 papers on the fatigue, comparing nurses to pilots, to bus drivers, on where they have a limit of 13 hours a day, 13 hours a day. Why don't we have that in nursing? Why do we think that nurses and healthcare workers can continue on and on and on and expect miracles? So that turned it around. And then it was that word burnout, and you mentioned it in your introduction. We talk a lot about burnout, but what I'm hearing from our nurses, they say, "Stop, Linda. I'm not burned out. It's not an injury. It's not an illness. I am morally worried. I'm morally injured of what's going to happen. It's that fear that's happening." So we, as an organization and provincial nurses unions, have been trying to change the language. Instead of burnout, talking about moral injury. Instead of staying there for 24 hours, after 13 hours, my dears, you should be going home. It's not worth the extra overtime and it's not worth the risk that you can give to patients. So it's, again, turning around that ship, that healthcare workers are going to be there regardless for their health, but also the patient safety aspect.
Is it understood everywhere that you can be told you can't go home even though you're exhausted? And is it an unwritten rule or is it a written rule and policy that you can be told, "Yeah, you need to stay, can't go home"?
Yeah, it's a fable. It's a horror story. In my days, when I practiced nurses 30 years ago, you could not, and your codes of ethics would say it. And we've interpreted the code of ethics of nursing of not abandoning a patient. And no, you're not going to abandon a patient. But if you're beyond the point of being able to safely care for a patient, you need to tell your supervisors, I'm beyond that point. I cannot care safely for a patient and I need to go home. And it has to be in writing. It has to be, you have to protect yourself and protect patients by doing that. So no one will say to a nurse that is incapable of working more than, and in today's society, it's 12-hour shift or 8-hour shift, but usually 12-hour. And we say around the 13-hour mark where you will not work. We have some collective agreement that say up to 16 where that's the limit the employer can give them. So our code of ethics is clear. We're there for our patient. We're there to do no harm, and we're not to abandon them, but we're not to put them in danger if we cannot function. And that's advising our employers.
There's still some variability, obviously. There's a big difference in those last 4 hours between 12 and 16, where I could imagine you would have a concentration of errors, if anything.
Yeah. And the evidence is clear. It's after 12 hours that the incidents, the errors, medication errors, and others start happening. And it makes sense. I'm sure you've worked 12 hours in your career, and I still work 12 hours in my career where it's like, okay, you shake your head and you have an extra cup of coffee and think what's going on. But we need to be more supportive, and we need to make sure that we protect the healthcare worker, that we protect the patient in our system that right now is in chaos.
And in those last 4 hours, it's not like distractions and interruptions go away. Everything keeps on at the same pace. And, you mentioned that you have to have someone needs to speak up to say, I'm incapable of doing the work for this. I'm too tired. I'm too exhausted. I don't want to impart harm. But is someone listening? Is that voice actually heard, or is it just muffled away through administrative convenience?
I think it's muffled away with a lot of prayers. People are just wishing that nothing's going to happen. But you, like I, read the news. There are patients that die in emergency rooms because they hadn't been seen or sent home when they shouldn't have, or stayed too long on a stretcher without being seen. So we're hearing those stories more and more, and it is sad. It is probably one of my worst fear is that we're going to have one of these cases that's going to disrupt the whole system with legal battles when we should be talking about safe staffing. We should be talking about work-life balance. We should be talking about mentoring. We should be talking about more teamworks. And yes, that might mean for a while your surgery is going to be delayed again. But do you really want a surgery when there's no qualified nurses and the healthcare team to take care of you when you're finished the surgery? The answer should be no. So until we stabilize things, there will be disruption, but it is for patient safety.
So with that administrative muffling of the voice and sort of, as you said, the prayer that hoping that nothing bad happens, you can't counter that when something bad happens by asking the nurse, well, what would you have done differently?
Yeah.
And they were asking to do something and they weren't heard. But let's switch to the stage that you work on now from a national vantage point. What is it that political leaders still misunderstand about the day-to-day reality of nursing work in 2026?
Again, it's that disconnect. A politician believes that they're in their ivory towers, either in Ottawa or downtown Toronto or Fredericton, New Brunswick, and they're just in these ivory towers, and they make a decision, and they're really disconnected from the reality at that 2 a.m. nurse. And we need to bring them back to the reality of think of that 2 a.m. nurse. Does he or she have enough support? Are they well staffed? Is that patient in the appropriate environment? Is the physician team well equipped? It's all connecting the dots, and a politician just sees it often. There are good ones out there, but sees it as a dollar sign. And right now, we're working with Jim Stanford, for example, a famous Canadian economist, on trying to convince these politicians that healthcare is an economic investment. So if we have a great healthcare system, that's good to bring business in Canada. That's good to bring business in all the little regions of our country. So it's not all about cars and buildings and pipelines. It's about that public healthcare system, that public education system, those public services that you need in a community to do it. And we're focusing, of course, on healthcare, but it is important. We're one of the largest workforce in Canada, and politicians still push it aside. Still, it's not a money-making thing, but it is a life-saving engine, and we need to get the politician to wake up and listen to more where the money should be going.
Either that or have them in on ward rounds more often.
Some have done that. Ontario, many politicians have went around the wards and do it. But the reality is, when a politician comes around, the manager makes sure that the desk is clean, make sure that, people are buzzing in the right direction. So it's not like we're doing spots visits. And that's what we have to look at, is how do you bring that reality to a politician? And not that I wish them any ill to enter our healthcare system, but there is a different reality when you walk in as Mr. or Mrs. Minister versus patient on a gurney with a Johnny shirt.
What I'm hearing here is just about a question of, for the sake of the team, and which knows no borders, from the nurse at the bedside to the manager to the administrators to the leadership at the health ministry, it's all about leveling that field of togetherness so we can all see eye to eye and move things forward.
Mm-hmm.
When we spoke with the nurses in Manitoba recently, they didn't say I'm tired. The resonant voice is, I'm scared. Scared of missing something, scared of causing harm. Is that a national fear now from your perspective across nursing?
Yeah, and that's what we were talking about earlier, the difference between burnt out, medically burnt out, the moral injury, or the compassion fatigue. You go into nursing, you go into healthcare for specific reason, and you have specific great qualities to go there, and compassion is one of them. So imagine you're trying to do your job and you can't do your job to your best ability. So every night you go home and, did I make a mistake, or did I provide the right care, or did I provide enough care? That patient, that family is still all alone and things are not going fast enough, or whatever the situation. So that compassion fatigue and moral injuries are terms that even pre-COVID, we weren't using it. We were using vacancies, overtime, burnouts, high absenteeism, and all that. But today, the language is changing on compassion fatigue, moral injury. And one of the worst, I think, is they don't want to work full-time positions. They cannot handle a full-time position. So they're telling us, my union, I cannot go work 37 hours a week in that hospital, in that long-term care. So find a way to reduce my hours. And that for the system is disastrous because it just means the vacancies are more and more and more because we need more hours to fill, instead of focusing of making healthcare jobs the best jobs in our community.
It just sort of sets the stage for the perfect storm. But what I'm hearing from you is that this fear is national. And I would actually argue that this fear knows no borders. And from some of the comments we've received on the podcast, after having spent time with nurses and the Manitoba nurses and others, is that we're getting answers from all over the world and comments from all over the world. And there's a unifying language here that people are speaking. And there's a unifying pain that people are experiencing.
Yeah. And Mark, when you look at big institutions like the Canadian Institute for Health Information, CII, as we know well, they are also reporting on burnouts overtime, but they're also matching it with patient injury. And the numbers are going up. They're not going up fast, thank God, but they're going up. And 1 in 17 patients in a hospital bed will suffer from some kind of injury, either medication error, complication, fall, because they're in that hospital. And they're flagging this is a trend going up, not going down. They're also flagging that the overtime, the vacancy rates, those are all going up. So we have to work on, put one and one together. What is happening is patients are not getting the appropriate care, and there's more dangers for injuries and more dangers for complication. So it is not only nurses unions talking about it, it is big Canadian institutes that are looking at data and saying, okay, there's something not jiving here.
Well, it sounds to me like a lot more people need to hear about this, and the word needs to get out. 1 in 17 doesn't sound like an opportunity cost we can justify, that's for sure. If we think about what Canadians need to hear, like if Canadians could hear one private conversation that nurses are having with you right now as their leader, what truth do you think would shock Canadians the most?
I think the truth would be the tears that they're really shedding. And it goes back to that moral distress or compassion fatigue, where what they tell me is, Linda, I can never do enough. Linda, I feel like I'm not worth it. I feel like management's not listening. Again, those are the negative aspect we're hearing. But then, though, there are areas of the country where we're seeing, okay, my employer is really trying, my government's really trying. So we as a national organization, I need to bring both of those together and boost it up. But the tears are probably what would surprise most, because you hear through their union the anger. That's our job as union, is to defend, to protect our members. And when you look at 93% of your members have signs of burnouts, that brings anger into me. But that member that comes and knock at my door or on the phone, her or him, it's the tears, it's the fatigue, is I can't do this anymore.
I think coming with that as well comes, and you alluded to it, is the guilt, but also the risk of the shame, where someone says, I'll never be good. I'm not good enough. I'm not good at this. I'm no good.
Yeah.
And then things take on much more drastic proportions.
Yeah, exactly. And that's in any job.
Is there one way that maybe even the public unintentionally contributes to the pressures that the nurses are under these days without even realizing it?
Yeah, it's the violence, Mark. We're only seeing violence, harassment, bullying really escalating. In the late 1990s, early 2000s, we were talking about, that 30-minute services or it's free attitude of society. You'd go quickly in an emergency room or a doctor's office or a nurse practitioner's office, and you'd expect it to be out of there in 30 minutes and everything be all right. Today, that's not happening anywhere, but we're seeing more and more violence episodes. We're seeing people bold enough to enter with arms, guns or knives or other types of arms in a hospital. We've never even heard of that. And I never thought that in 2025 and it's going to continue in 2026, that we would be lobbying government to fund metal detectors machines into a hospital, and they'll be in long-term care facilities soon, because I see that money should be going to the caring budget. And the caring budget is nursing's, personal care workers, is physician, the whole team. And all these millions have to be placed into metal detectors and more security, because we have a legal responsibility. Just like politicians need to be secure when they're working in their legislative assembly, our healthcare team needs to be secure. So that is a shock that I have a hard time accepting. I know we have to do it, but that's where society is taking their anger in the wrong place. Instead of buddying up with nurses, with their unions, and saying, okay, we're going to support this campaign, and it's not going to be 1,000 signatures sent to the premier. It's going to be 50,000 signatures. It is time to stop.
Absolutely. And then there's the safety of our patients, who are usually in close proximity to these violent events and who potentially can be collaterally injured. Just this weekend on CBC, there was a feature about metal detectors that finally went up in one of the provincial hospitals in Canada, and the harvest of objects they found is undeniable.
Yeah. One of my presidents got the government to put metal detectors in certain of the hospitals.
Mm-hmm.
Then the debate was, well, if I find a gun or a knife, we have to pay for the boxes, the security boxes, for the patients to put it in so they can get it back when they leave. And that blew out. That blew out of the proportion, because, like, really, you're not supposed to enter a public institute with those arms. They should be confiscated and brought to the police, and let the police deal with it. And that's one thing in healthcare we don't do enough. We expect the nurse manager or the nurse herself or himself, if there's a violent issue, you decide if the patient's going to be charged. Well, the last time I checked, I am not a legal authority, and neither is that nurse manager, neither is the VP of the hospital, honestly. It should be an automatic that if it happens, if a violent incidents happen, it goes to the police and they decide who's going to be charged and not charged, not the individual nurse. So it's a lot of discussions happening around the violence portfolio, from metal detectors, as we just talked. But then what happens if something violent happens to these nurses?
Well, and that just can't be branded as part of the job, right? I don't think, and the best barometer from my perspective is always, if I had a child who was entering the profession or was a young professional nurse and was facing these risks, how would I feel as a parent? And there's no way to rationalize violence as just part of the job.
No. No, but we're doing things to change it, though.
Tell me about that.
The first campaign against violence that I participated on was in 1991. So a lot of your listeners are probably saying, Linda, I wasn't even born in 1991, or at least not practicing nursing. But back then it was a poster: no violence, or violence not accepted here, and that's about it. Well, today we were even able to change the Criminal Act. So now the Criminal Act says that any physical assault or harassment on a nurse, a healthcare workers, will be an automatic 10-year charge, 10-year assault charge. I don't remember the exact legal language, but in normal lingo, you and I know if a police officer stops you for speeding and you attack him or her, you know you're going to be charged automatically. There's no ifs or buts. It's the same laws for healthcare workers. But the public doesn't understand. Honestly, the police don't understand it yet. So we have to do so much education on the laws as change. You protect a police officer, you protect a nurse in the same vein. And how do we do it? So much progress has happened in 30 years, but now it's the education, changing that culture that nurses are there as angels of mercies and they'll just accept everything. Nurses are very strong, educated healthcare professional, and are there to work with a team, and they're there to be respected in the same way. And it's not punching bags because you're frustrated the healthcare system is not providing you what you need.
So, on that theme of education, I mean, there's so much is getting messages out. And I've often heard you say that the solution to many things is also staffing and then staffing and then staffing. Can you help our listeners understand a little bit about what not having enough nurses on duty looks like from a patient's perspective? Like lying in a hospital bed, pressing the call button, and no one's coming. It's not because there's a choice being made to ignore. It's usually because people are caught between distractions, interruptions, and concomitant duties because there are just not enough individuals to go around. Walk us through that. What does it feel like?
It's those near miss. Those near miss are the ones that make you sick to your stomach. That you realize that if at that split second you wouldn't have caught the blood pressure crashing or looking at a dressing and thinking, oh, it's not the same color it was 2 hours ago. I need to go check it. And then you open it up and everything blows. It's all those near miss. Or it's an absent of holding somebody's hand that you're so much in a rush and they've just received a disastrous diagnostic and you and the physician just have to leave the room and you know they're alone and somebody should be there. It's all of those situations where it should not happen. Regardless if it's a happy event, just like the birth of a baby, that environment should be well protected, well cocooned so the family can enjoy it. Or at the other spectrum where somebody learns that their life is going to end soon or it ended, how do you protect that? And we forget that that's all part of our healthcare system. It's not only the high energy, high technique surgeries, the big machineries. You need an MRI, you need this and that. That's all important, don't get me wrong, and we need to get them on time. But there's also that supervision. A surgeon cannot do your surgery, if there's not the appropriate nursing staff to go and monitor you either for 48 hours, for 72 hours, sometimes for a week. Then it's rehabilitation. If you don't have your proper rehabilitation, what happens? Well, you stay longer in the hospital, then everything is slower. So it's all of those systems that we just think, I need my surgery, I need my surgery. How come I can't get my surgery? Well, it might not be a surgeon shortage. It might just be that there's not a bed shortage because we have those. It's the staff to take care of the patient in the bed.
I can tell you that in my medical career, the most memorable times of that feeling of unity was when the team of physicians and nurses were all on the same page and we felt like we were all looking towards the same goal. And I can tell you last night I was in the ICU with a gastrointestinal hemorrhage that I needed to treat, and I needed my team there. If I was there alone, I couldn't have done my job. And collectively, we supported each other through it. And when it was all done, we looked at each other and said, way to go, team. We did it.
Yeah. I remember those in intensive care too. And it's true, it's 30 years ago, so the system was different. But it was this feeling of it was not success. It was that taking this deep breath of relief and then looking at the patient in the eyes and feeling so great. And still, like 10, 15 years after, I live in a small town in New Brunswick, I'd see patients or family members recognize me of being one of that nurse, part of that team. And, they remember the good story and they remember the sad events too. But how can we make such a difference together? And it's important for me to understand as a nurse what your qualifications are, and for vice versa, for you to know what my qualification, my experience is, and build that trust. And as you would know, it's not like TV. We don't see our healthcare system as what's happening on TV.
Linda, you hear lots of stories from nurses. Do they ever come to you after a patient has spoken to them about their despair when they were calling for help, but no one could come when they needed it just because of the understaffing. Like, do you hear those stories too? Nurses coming and saying, this patient broke down. They were so upset and scared, and I just needed to listen to them.
Not to me directly, if I'm honest, because being national president, there's a few steps in between. But when I go to annual meetings, those are the stories that we see from the floor.
Mm-hmm.
I'm an ER nurse. I can't take it anymore. These are my neighbors that are coming through the doors and have to order pizza because they've waited so long. I have to sleep on the floor. I had to give a blanket for a husband to put their sick wife on the floor or their sick child. Those are the stories that are coming out. And that's why you're seeing so much frustration and anger coming out of messages from unions, is because this is not okay. This is not okay for the community we're trying to serve, and it is not okay for the workforce that should be so cherished and protected and respected. We need to fight to get better. So it is, how do we work with governments? Right now, the big project everywhere across the country on safe staffing is nurse-patient ratios. And some
Mm-hmm.
will say, oh, it's too much of a blunt tool. Well, how can you have 20, 30 years of academic reference, academic evidence that in med surg, so on a normal, if I can call it, floor where you have surgeries, you have medical patients, you have a mixture of all, you should have one nurse for 4 patients. Some parts of our country, we have one nurse for 8 patients, 10 patients. We know that's not safe, but we're still doing it. So how do you bring those numbers in that will bring patient safety, but also will work on retaining your nursing staff and the rest of the team? Because, it's like in a household, I'm being a bit sexist here, but happy wife, happy home, happy nurse, happy results in the healthcare system. And we have to really move towards safe staffing and find the right formula for every facilities. And that they're working across Canada. They're calling it all different things. So I'm thinking, let's do an interview in 2-4 years, see where that follows up and see where the progress has been made. And I'm hoping that it will be made across Canada.
I think there is some progress being made. I think there have been some announcements that in certain provinces, this is really at the forefront, if not law already. But
British Columbia.
on that note, how's it going to be implemented? What's the formula to then implement it? Because it involves change and it involves potentially silos actually having to talk to each other. One thing is putting it in law. How do you enforce that law?
So putting in the law, it's only Manitoba talking about putting in law right now. And some of the work, they have a committee that is across the province from the union, academy, employers, governments on where to start. So, there's progress there. And we were very impressed when the minister announced that we're going to have legislated nurse-patient ratios. That's a start. British Columbia is more ahead of the game. It's about 3 years where they've been working, they've implemented. They're going to have the first in the world of 1 to 4, 24 hours a day, because the evidence has changed. As you know, as a physician, nowadays a patient at 2 a.m. It can be as critical and as needing medical needs as at 2 p.m. So how do you make sure that 24 hours a day your patients are taken care of? So there in Nova Scotia established a new system where Nova Scotia is a lot more rural, different. Well, is 1 to 4, for example, working for one area of the province versus the urban areas or the intensive care emergency. So a lot of discussions. What CFNU, my organization, has done is we've just formed and are funding a national council for nurse-patient ratio implementation. So we're bringing employers, government, unions, and researchers all together and say, let's not talk about the evidence if it's good or not. We know that. But let's talk as different ways on how can we implement that? How can we give the guarantee to the nurses coming in at 7 a.m. that the staffing will be safe, and giving honestly the same guarantee to patients that the staffing will be safe. And so we're starting to work on that. Our big workshop will be next fall.
You mentioned good enough. Is the evidence good enough? I mean, that's subject to a lot of interpretation, but I guess the real question is, it's sufficient? And not just quantitative, but qualitative, because I think the stories speak for themselves, and that's data also. I look forward to maybe having you back in a couple of years and getting an update on that topic, because I think that's huge and I think it's progress. And the scary thing is that it goes beyond that. I've heard stories of 1 in 50 ratios in other institutional settings or in private settings. And you're right, with the level of complexity of patients these days, you don't just get unstable or sick at 2 p.m. It's around the clock, because you've just got so much more complexity per patient that the odds are something is going to happen anytime. You know, we touched on violence a little bit earlier, and that often includes sexual assault. What are nurses experiencing these days in that area? And is that handled any differently after they report it?
No, I don't think it's handled any differently than any other violence incident. And again, it's a cause and effect of our system. Uh, our surveys, and we survey our nurses on a multitude of stuff every year. The last one came out last March, in March 25, and 18% of nurses were saying to us that they got sexually assaulted. And those numbers are going up. Is it that they're reporting more, just like in society in general? But it is still a big issue. We have to consider, is it that we are still at 91, 92% female? Is it a gender issue? It is hard to pinpoint why, but it's also and I'd say as disgusting when an employer doesn't recognize it. We're past the stage of what could you have done differently. We're in 2026.
You're
And
right.
if an employee tells you that they were sexually assaulted or in a violent situation or bullied or harassed, we need to believe them and act appropriately. And we're still hearing nurses telling us, why would I go to my employer? They told my friend, what could you have done differently? Or they told my friend, just shake it off and continue your shift.
This has been normalized for so long, and not just this type of assault, but other types. But who's benefiting from pretending that it's inevitable? Like, who's benefiting? Is it because leadership doesn't want to deal with what leading has to do and has to be to get someone through such an event when they've experienced assault? I mean, it calls on leadership to step in, but what I'm hearing is that it's just batted back to the individual. Do we need more leadership training? Do we need more leadership criteria before someone gets promoted to a leader, more than just seniority, for example?
Yeah. Yeah. I think you hit it right on the head, Mark. It's about training and resources. You cannot do interventions like that on the side of your desk. You need the training and you need the time to do it. And that's what's happening with a lot of managers. Like I say all the time, there's great managers out there, and some of them are just scared to do a mistake too. So it's easier just to shove it off and make sure nobody talks about it than dealing with it. Takes a long time and a lot of energy to deal with an issue like that. But if you respect your team and you're there to enhance their work life, to protect them, you need to deal with them. And then it's higher up. How do you provide the support? How do you provide the training? Or is it that person that should be dealing with it, period? So it is all a thing of staffing. There was a research paper done just before COVID where it talked about management in a hospital. And in healthcare, like on a nursing unit, they manage 10 times the number of bodies of individual of employees than you would in the private sector, for example. Why is that? Why do we again expect so much more in a caring profession that we would expect on a police force, or do we expect in another industry?
And when nurses finally decide, I can't do this anymore, and unfortunately, too often now, it's sometimes within the first 2 years of starting their careers, what usually truly pushes them over that line?
Nobody listening to them. We have about 1 in 4, 1 in 3, depending on the surveys of our early careers, is saying, I'm not retiring in nursing. I'm not staying. I'm looking for the exit door. And when we ask them, you expect to hear the shortage, the overtime, the scared of doing a mistake, and all of that. But what makes them tip is really not being listened to, not being respected. And they say, why would I stay here? Why would I work 12 hours night when my colleague is, working 8 hours and receiving glories from her employer in a different work environment? So it's really that listening and that respect question.
Work environment, you mean the difference between public and private? Or what do you mean? Do you mean just a different organization?
Different organization. The problems we're living right now in healthcare, it's that caring profession. Society, employers are expecting a lot more of somebody like you that went into medicine, or somebody that went into nursing or psychology, and the names are all there, because of that caring aspect, saying, Mark will do a little bit more. Mark will do a little bit more. Linda will do a little bit more. And there's always that attitude of not respecting the individual as a professional worker. And that I tell to all my nurses, regardless if you're a registered nurse, a nurse practitioner, a licensed practical nurse in Ontario, there are RPNs, or a site nurse, is remember, you are a professional worker. And as you as a physician also, you are a professional worker. So you have rights as workers, just like the bus driver, the police officer, the construction worker. I'm sure you were working during COVID. Why did we have to fight for PPEs? Because they expected us as healthcare workers to go and work and beyond and be always about that. I will not give up. I will push the limits, which is all true. But as a worker, you have rights to be protected. You have rights to have normal working hours. You have rights to have proper staffing, proper equipment to protect yourself if need be, and training, etc. The list goes on. So it's that changing of mentality of telling our professional workers that you are professional workers. And employers, for example, there's occupational health and safety laws across the land, and you are obligated to protect those. And that goes from violence to overwork to harassment to PPEs, personal protective equipment. You have a legal obligation to follow that. And we need to push the limit on those.
Well, the hope there is that the person behind the worker gets recognized, and everyone's their own person too. And I've heard a lot of comments about how there's a person hiding in there who shows up every day with their own history and their own person issues, and they're trying their best to get their job done as a worker. We talked earlier about nurse-patient ratios, and maybe for some listeners that still sounds a little bit abstract, but during a single shift, what does a safe ratio actually change? Not only for the nurse, but for the patient.
It's focus on safety. It's focused on expertise and what the patient needs. And that's when we talk about nurse-patient ratios. It doesn't mean the same thing on every unit, doesn't mean the same thing for every nurse or every patient, because let's be honest, if I'm a 20-year graduate and I've worked on that unit for 10, 12 years, my level of expertise is different and higher than a new grad that enters. So you might need two new grads for one experienced nurses, all depending on the qualification and experience they all have. But what it means for the patient, it's a question of safety. It's a question of caring, answering their needs. On their side, also, if the patient always has a member of the family attending with them almost, 24 hours a day, well, there's personal care needs that might not be needed by the healthcare team. So that's all factored into what we call ratios, which is a simple formula of on a unit, it's either one nurse for 4 patients, one nurse for 6 patients, or in intensive care, ER, it's one nurse per 2 patients. I've seen 2 nurses for 1 patient, all depending on the needs of the patient and then the experience of that nursing team. And I emphasize on the nursing team because it is depend who's around and what's needed. If the nurse, the registered nurse, doesn't have anybody else to work with, then you need less patient loads, of course, because you're doing everything. So that, in simple words, that's what we're talking about ratios. But it's really changing a focus on the safety and the patient's need of what during that shift.
You spoke to me earlier about that nurse in the ICU who had done a 30-hour shift. What was their ratio? I would only hope it was 1-to-1. Can you imagine it being anything more than that after 30 hours?
I know. It is hard to imagine how that went on. I'm from rural New Brunswick, or from New Brunswick, and I remember working intensive care where, we couldn't go home because it was a snowstorm. But there were areas where we could take a break. There was areas where, between units, and we talked about it earlier too, in your experience with the teamwork. Okay, you go sleep an hour, I'll close the door, close the light, and then we'll switch, we're able to do that. Today, they're not able to do that as much, even in different events, but hopefully that nurse had a one-to-one ratios and 1+ support of others for sure.
So with the vision for change, if we imagine a system that's actually working and starting to improve and meet those goals, what's the first thing a young nurse is going to notice that's telling them, this is safe, this is sustainable, I can stay here?
Mm-hmm. The first thing she will notice is that they have an excellent mentoring program, that they're not thrown to the wolves. And that's one thing we do too much in nursing, where you're starting and your orientation is like everyone else, your 7 days or for 1 week of where's this office? Where'd you call? How do you fill these forms? But we forget about the mentoring of the nursing care on a unit, and it changed from unit to unit. So it's not only the new nurse coming in who graduated in May, it's about a nurse who worked 10 years in labor delivery and is changing to go work in intensive care or working in orthopedics. We need to surround them well so they feel secure. So when a new grad or somebody switching floors notice that, okay, they're really going to surround me with experience, with mentoring, and I'm going to feel secure, that's when they're going to stay a long career in that facility.
Problem is you can't assign that mentoring role to someone who's burned out and dealing with a 10-to-1 nurse-patient ratio, because that's setting the stage for failure in mentorship, because they just won't be able to provide the mentoring for that new trainee who's just joining the team, and questions may be difficult to ask and maybe greeted with less than receptive warmth.
Mm-hmm. For sure.
Partly part of that spectrum of burnout and compassion fatigue, even compassion to the new nurse who's joined the team, who's there to just ask a few questions to help keep them on track.
Mm-hmm. And when you think about it, not everyone is fit or wants to or likes to be a mentor or preceptor. You have to get a bit of training. It's all about adult education, but you have to enjoy it. So sometimes it's better to skip the next one. If a nurse manager hears from one of their team members, I just hate it. It makes me nervous. I'm worried. Well, skip to the next one. There are people that just loves it, and that's what makes or break a good nurse, a good young nurse.
Yeah, it's probably good to fill those positions slowly as opposed to as quickly as possible when it comes to choosing the individuals to take that next level of leadership.
That goes back to retention and also returning, where we're finding a lot of our nurses are leaving the workforce early. Before you would see retirement, after 60, after 65. Now you're seeing it earlier. Well, most of them would love to be called back and just do mentoring. Why don't we bring back that experience into our workplaces? How do we convince our nurses that work on the unit for such a long time to bring back their expertise, to share and continue on building? So we have some facilities across the country doing it, and it's a big success.
That's brilliant. It really is. And we've got the clinical nurse educators on different units, et cetera. But the clinical mentorship educator, wow, that would be next level for sure.
Mhm.
Do you really think that with everything we've spoken about today, and if people understand things that much more from this conversation, that you will still be having to tell high-level ministerial people in health that staffing saves lives? Like, do we still have to prove that in 2026? Or is the data there, and do we just need to spread the word?
The data's there. The problem right now, it's the money. Everything's attached to a dollar, cent. And, I look at the federal government currently. It's budget, budget, budget. It's how do we deal with the economy. So our job is really bringing both together and showing, as I mentioned earlier, that our public health care system is an investment. In regards to the staffing, it's what we're asking the federal government is to create some kind of patient safety guarantee, patient safety charter. But for those Canadians or people living in Canada that are going in our healthcare system is not free. We're paying it through our taxes, regardless of the level of taxes you pay. But that's what the guarantee we give to Canadians is: you pay your taxes, and we will provide you not an education, but an education too, but a healthcare services when you need it. And right now, the number one priority for Canadians is primary healthcare. They can't get a primary healthcare provider, regardless if it's a family doc, a nurse practitioner, pharmacist, or others. The list is long. They can't get mental health services, seniors care. We could do a whole show just on seniors care and how do we move away from long-term care to really thinking of what do seniors need, that aspect. But the federal government, because we're such a small country, should be able to establish what are the guiding lines, what are the hope, what are the guarantees that we're giving everyone, and have the province and territories be transparent on how they qualify, how they evaluate themselves on it, or have the CII, the Canadian Institute of Health Information, evaluate everyone on those standards. And primary health care is number one. It is not acceptable that depending on what you read, 4 to 6 million people do not have a primary health care provider. That is scary, because if you have no one to call and you have to go to the emergency And we know the horror stories of waiting in emergency and leaving without being cared for, or going to a private clinic and then there's no follow-up. That's when you get in trouble and with your own personal health, and that's when you get frustrated too. So how does the federal government brings a higher priority on what is our promise as a nation to provide healthcare services? We have to focus on patient safety.
Linda, we always want to champion innovation, but from the value perspective and from the lens that you look at things every day, what provides more value to Canadians? Innovation in illness care or innovation in healthcare? I don't think they're the same.
Yeah, I would say innovation in healthcare, but even innovation is a big complex word. It can be as simple as having enough time with your primary healthcare provider, or having them being able to transfer you immediately if you need mental health services. It's not everyone is a mental health expert, but we need to be able to refer. We need to be able to provide in a community if it's a quick diagnostic and it's within the scope of practice. Well, why can't you go to your pharmacy and get? But all of that has to be well secured under patient safety.
Mm-hmm.
So I think innovation in healthcare is how do we give access to healthcare needs of our communities, and it's different in Prince Albert versus downtown Toronto. Very different, but it should be different, and it should be mobile, and it should be flexible again. And then when you need your emergencies, when you need your surgeries, when you need your hospitalization, that's a focus that is very different than primary healthcare. It's a focus of that's where your different technologies come in. That's where your staffing issues come in. That's where your different training comes in. It'd be hard to put a nurse or a physician that only worked in intensive care, put them in a community health clinic. I remember a story when I worked in I worked in intensive care and then emergency, and I went in labor delivery after that. And my first woman that fainted it, I was about to call a code 99, and these senior nurses looked at me, which is a cardiac code for our listeners, but looked at me. She fainted, Linda. She just delivered. And for me, it was, I just saw cardiac arrest. So, at the end, it was a funny story, but it's a nurse is not a nurse is not a nurse. You need different training, different environment, and goes the same thing when any of our providers. And that again goes under the umbrella of patient safety.
We hear about more money going into healthcare, attempts to infuse more money into healthcare, yet nursing retention is still failing.
Mm-hmm.
What's it going to take in the year ahead, in the years to come?
It's safe staffing and respect. That's why we're putting so much energy on nurse-patient ratios. Nurses are telling us that if you give me the tools to do my job properly and you respect me as a professional worker, I'm staying. I went into nursing for a reason. Right now, we're at the tip. We're just moving into it across the province and across the country, and some provinces are not even touching it. But that's how we're going to save our nurses. That's what happened in California, where they were the first to legislate nurse-patient ratios. They don't talk about retention in California, and it's not about the beaches and the sun. The nurses go work there because they know that in the majority of their big health facilities, there are specific ratios and they will be followed. And then we're seeing in other states in the U.S. We're seeing it in Australia, New Zealand, Ireland has a different system. So there are pockets everywhere that the employer and government are respecting the professional work of a nurse and giving them the tools. So that will fix retention. Recruitment is still there. Our schools of nursing are still filling out the seats. It's just when they walk in the workplace, 30% of them are saying, I'm not staying.
It's a shame. You've alluded to, concerns about relying on for-profit nursing agencies, but does filling these spots with nurses from for-profit agencies change anything? I mean, it's a fill, but it doesn't change the dynamic. It doesn't change the nursing experience. Like where does the concern lie, and how does it cause a problem?
Well, on two aspects. Earlier in our conversation, Mark, we talked about teamworks. When somebody's just plucked in to fill in a shift, there's no teamwork there. It is very hard to build that team. And are they going to be there tomorrow? Are they not going to be there tomorrow?
Never see him again. Yep.
Yeah. And there's no engagement to the employer. There's no engagement to the team. They're there to do a job, which is 8 hours or 12 hours on that unit. And then hopefully they'll come tomorrow. So instead of investing into your team, into your community, you're plucking holes with agencies. And we're seeing employers across Canada spending millions, and we're seeing auditor generals questioning it. The first one was in Ontario, Newfoundland, Labrador, PEI, Nova Scotia, New Brunswick, and we're seeing other provinces. Okay, we need to start looking at it. Manitoba is one of them. Where is that the right way to spend our public dollars? So that's the first area, the theme. And the other is really for the individual. There's no guarantees. One day agency working, and Manitoba is the province where they've done the most progress on it. Agency work is going to finish. You will not have a job. You will not have a pension plan when you hit 60 or 65. It's very individual. So you're making a lot of money today, but there's no future. And how do we fix that? Again, it's about working with the team. It's working to make sure that these employers become the best employers in their communities and invest in your community and not in this private sector company that opened and God only knows where.
Well, it's hard to build collective awareness and buy into a mission, whether it's on a nursing unit or on a ward or in any part of a healthcare institution, where that culture, that team culture is really important, and it can't be nurtured with a culture of transience. You're absolutely right.
Yeah. We know that when a new nurse comes on the floor and new employees, it's you have to build them in the culture. Every unit is different.
I think 25 years ago, or 30 years ago, it was a lot easier because the nurse manager often was a career nurse manager on that same ward. They stayed there, and they identified with it. Everybody identified together. And when I was a resident in Montreal, I remember that you knew the culture of each ward, you knew who the leaders were, and it was palpable. You could just remember it. And I have very fond memories of just the collective. And as residents, you joined in and you melded, you learned your faux pas and things like that. But if you really wanted to experience the delivery of care to the patients on your ward, you just melded it with that culture. And it took skill, there's no question, but it was very rewarding.
That's one thing nurses ask us also. Can you bring that old head nurse type back? We need a head nurse that knows the unit and will be there for the unit and not for being at a meeting on the second floor of administration. So your story about the head nurse is very much appreciated by frontline nurses, those that are at the bedside. They need that cheerleader that who knows what they're doing for them.
Well, their office was actually very often on the ward, right?
Mm-hmm.
I remember that distinctly. And you knew where to find them. If you had 5 minutes alone with a finance minister who still believes that private agencies provide equal flexibility and have something to offer, how would you argue economically that having permanent staff and ensuring permanent staff actually matters more?
I think if I'd have 5 minutes with a provincial finance minister, I'd bring an employer there with me, and they will show how high cost an agency nurse is and how high cost it is not working for them. I probably wouldn't even have to talk about it because employers across the country are telling us this is bankrupting us. This is putting money where we're not supposed to be putting money in. We want to invest in better care, better technology, and their list is long. So that's what I would do. I'd bring an employer and say, tell them how much you just spend on agency nurses. Why? Because you can't retain your nurses. And how do we fix it? We work together because we really have to put the government, the employer, and the unions, the nurses unions together to work on ratios, nurse patient ratios, for example, on mentoring program, we bring in the students. So it's more showing them the dollars and cents. You're talking finance minister, so it's all about the evidence. And then what are your solutions? The solutions in healthcare is really bringing everyone at the table and how do we find better solutions?
And showcasing the value. I think the understanding of the value of the success stories is probably not always understood. So for one nurse who's listening tonight somewhere in the world on night shift, or one family caregiver who's listening right now, you talked earlier about not 5,000 signatures, 50,000 signatures or more.
Yeah.
What's one action that can actually create pressure for change? How would you invite caregivers, nurses, of course, people who care in our society to create that pressure for change?
Well, to create almost the perfect storm of pressure for changes, we have to collectively agree on our message. And that is one of the downfall of healthcare. There are so many needs out there that we bombard politicians with 1,001 needs. For nurses, we've tried to focus on funding of healthcare, so depending on the level of government, which should go directly to staffing, directly to patient care. Other is enhancement of our healthcare system, such a national pharmacare program. And I really try to say, let's stay focused on that. And when we don't focus, politicians pick and choose. And that becomes the danger of all of us. We're working better with national organization and provincial organization like the CMA, the Canadian Medical Association, both nationally and provincially, with the nurses and other healthcare professionals to say, okay, how do we give a common ask with different messages? Because all our messages are different, but the ask remains. So where we really focus commonly is on the financing of healthcare, and then telling the politicians, finance it appropriately with great standard, and then let us do our job. And that works when we're able to do it.
It's so much goes into that final product, as you say, and it starts from identifying the shared values and the shared motivations and the shared targets. And part of that, it just revolves around communication and that bigger inclusive understanding of what it all takes. If we were to imagine a bedside geriatric nurse here in Canada, or a community practice nurse in the UK, or a pediatric nurse in Australia, or an ICU nurse down in the States, or a family caregiver anywhere listening right now, after our discussion today, what's the one truth you want them to carry with them forward from our conversation today?
Probably don't quit. We have to have hope that decision makers are going to see the light, and they will. I've been involved in nursing for 40 years now, and I've seen the ups and downs of no jobs to shortage, no jobs to shortage. And there's always ups and downs. But at the end, the decision makers see the light. And right now we are at, I don't want to say the worst, because I think the pandemic was the worst and the best, because everyone was focused on a problem, and we were able to put resources to it. But now is organizations are starting to see, okay, there are solutions out there, like the security that we talked earlier. Nobody would have thought that we'd ever put metal detectors and higher security in hospitals. But now we're seeing it. Okay, how do we move forward with nurse-patient ratios? How do we move forward with mentoring program? And we're talking nursing now, but it goes for the whole healthcare team. So how do we move forward on this team approach for primary health care? How do we guarantee everyone living in Canada will have access to a primary health care provider and they work as a team? In Ottawa, when I first moved in Ottawa in 2003, I had a nurse practitioner. They weren't popular back then. There was a handful everywhere. But she always worked, happened it was always a she, but always worked with a family doctor team. So if they didn't know what to prescribe or what test to ask, they'd walk across the hall and the family doc was there. They'd work with a physiotherapist, etc. The problem with them is that there was no retention programs at all. So they were all working part-time. We're working to change that to bring more of an equilibrium on it. But it is about don't quit, and let's, as a team, stay focused on improving the fate of our healthcare workforce, which will improve the fate of our community.
Linda, we've touched on so many important topics today, and your answer, don't quit, really resonates with me. But I think the follow-up to that is look around, because when you have a lot of people thinking don't quit and they look around and they see other people saying don't quit, you realize you're not doing this alone.
Yeah.
I'd really like to thank you for joining us today.
Oh, I thank you.
This was an amazing discussion, and you're a champion, and I look forward to hearing good news, and we're seeing progress and awareness being risen every day. And as we rise, we'll see the changes.
Thank you very much, Mark. And thank you for doing this on your spare time. But thank you for your career in healthcare. It's important to show that there are hope out there and that we're all working together. So, un gros merci.
Merci beaucoup et à la prochaine. Et je te souhaite du grand succès.
Merci.
Au revoir. Thank you, everybody. This wraps up this week's episode of the Caregivers Podcast. Until we meet again, I'm Dr. Mark. We'll see you next time. Before we wrap up, I wanted to remind you of something important. The conversations you hear on this podcast are here to inform, to support, to spark reflection. They're not a substitute for professional medical advice, care, therapy, or crisis services. Listening to this podcast does not create a doctor-patient or caregiver-client relationship between us. If you're facing a medical concern, health challenge, a mental health challenge, or a caregiving situation that needs guidance, I encourage you to reach out to a qualified professional who knows your story. If you're ever in crisis, please don't wait. Call your local emergency number or recognize crisis hotline right away. You deserve real-time help and support. The views you hear on this show, whether from me or my guests, are our own. They don't necessarily reflect any organizations we work with, or are part of, or have worked with, or been part of in the past. This podcast is an independent production. It's not tied to any hospital, university, or healthcare system. Thank you for being here, for listening, and most of all, for taking the time to care for yourself while you continue to care for others. I look forward to hearing from you.